Thank you for doing all of that. And may I welcome every one of you to the December Conway Chair Conversation. My name is Pam Hines, and I have the amazing privilege of being the chair holder for the William and Joanne Conway Chair in Nursing Research. And as part of that work, we created the Conway Chair Conversation, a monthly offering that is strongly supported by Conway scholars. And I believe today you will see Dr. Vicki Friedenberg, Dr. Lisa Ring, Eileen Eng, and Joanne Wilson, and Dr. Randy Streisand, all joining us today. I wanted to talk a little bit about the purpose of the Conway Chair and then why it is that we have the two stellar speakers today that we have. We firmly believe that in research, that we want very much to bring together clinicians, researchers, and translators of research to make clinical care better in pediatrics, our community, and our families. And to do that, we think there should be time when we can bring a topic forward that we can discuss, debate, agree or disagree. So we always have speakers that we feature, sometimes panelists as well, but you as attendees also have a role, and that is to be lively, to challenge, to question, seek information. And won't you please do that through the chat box, and also at the end of comments today, we'll be inviting you to speak and address your questions directly. So it's a great opportunity for us to bring clinicians, researchers, and others together to think together and to make for improvements in clinical care. So sometimes we can bring research and clinical expertise so closely together that something results, and that result is innovation. And that's what we're going to hear about today. This is part of a theme that we have been focused on for a number of monthly sessions. And today we're going to be talking about the CRI, which is a new approach for censoring when we might be in danger of a hypovolemic status going into a low status. We have two incredible speakers, and I'd like to tell you just a little bit about them. I'm going to start with Cindy Colson, who has actually been in healthcare for over 2 decades. She started as a paramedic, then went on to become a nurse. Now she's a master's prepared nurse, and she is actually leading injury prevention, education, and outreach on behalf of the team that she represents here today from Trauma and Burn. She is currently also a doctoral student at the School of Nursing in Johns Hopkins, and she's a published author, both papers and a text. So it's really a great pleasure to have her here with us today. And along with her is another person who I really like and admire, and that's Dr. Randy Bird. I know you know Dr. Bird. He doesn't lead just one division, he leads 2, and that would be trauma and burn. And as you know, we have been appointed centers by the state, by the district, and beyond nationally in those areas. And I really credit Dr. Bird and his team. He's also led some very sensitive research that's been well received in our own emergency department, and that is the careful look at how we do resuscitations. The look at the performance of each of us, including leadership. So it's a very well-rounded examination on a sensitive topic of how we can be made better. And people in the emergency room I have such regard for, because they are very invested in this research and very much listening to what he's finding. His research is funded by NIH and also NSF, and that's a really strong statement about how well regarded his research is. So I welcome Cindy Colson, Dr. Randy Bird to the December Conway Chair Conversation, and happily I turn this over to you, and I look forward to listening and learning well. Please go right ahead.
Okay, and as a double check, you guys can see my slides, yes?
Yes.
Perfect. Okay, so I'm going to talk about this device that, you know, when we have a kid who presents in the emergency department in hemorrhagic shock, it's not always obvious that kids in hemorrhagic shock, because we have an advantage taking care of kids is that they compensate quite well for their hemorrhagic state. And this even happens in adults. And so you're compensated when you're in shock, but then suddenly you fall off a cliff. And this is something that we've been very interested in. We've had a lot of kids that they've had delays in their initial treatment of hemorrhagic shock. And we wanted to figure out better ways to do it. And this is one avenue that our team is now approaching. And this is a research project in play. But I think it's a good discussion to hear about what we're doing, why we're doing it, what the barriers are that we've had for implementing this protocol at our hospital. So hemorrhage is a bad problem. Now, trauma is the leading cause of death in individuals up to age 45. I wish the NIH knew that and allocated their fundings proportionally to that. But this is an important cause of mortality. And if you look at preventable deaths from trauma, most of them are related to hemorrhage. And most of those deaths are occurring within the early hours, within the first 6 hours or so after injury. And the way shock progresses is you have this sort of injury insult of some sort, or some physiologic insult, maybe sepsis or something like that. And as you progress down this hierarchy, you can have compensation. Initially the body compensates, often if you can identify the patients in this compensated state, often you can fix things without any irreversibility. But a lot of these patients will have absolutely normal vital signs. And so this compensated shock state is difficult to identify. Once you move down the ladder, sometimes you can't avoid getting down to the black triangle, the black rectangle of death, which is characterized by initially by acidosis, coagulopathy, and organ damage, and you can't do anything about it. So the goal of this project is try to figure out how we can figure out when the patients are in the upper part of these rectangles. And this is the physiology, a simplistic graph showing the physiology of adults and kids when they are in a shock state. And in adults, you very quickly, as you move to, and the x-axis is volume loss, and the y-axis represents either heart rate or blood pressure. And what happens in adults is that you have an early heart rate response and blood pressure response. In kids, this makes it's much different. Kids compensate by tachycardia to maintain their blood pressure for a long period of time. And what happens is you have this step off the cliff phenomena that eventually all of a sudden the patient just does poorly. And so trying to figure out when patients are in these early stages to avoid falling off the cliff, we need new innovative approaches. And so what's currently done in a pediatric setting is people look at normal vital signs and look at normal ranges and say, well, this patient is out of the range of normal blood pressure and normal pulse and respiratory rate, and adding on things like perfusion and cognition and things like that to try to figure things out. But these things really don't work. And as I already mentioned, is about 20% of even adults have normal physiology, have normal blood pressure, normal pulse, even in the presence of a hypovolemic state. So the traditional things that we do for diagnosing hemorrhage just are not adequate. I already talked about the vital signs, how they're delayed. And then, you can do blood tests. You can get a hemoglobin, you can get a lactate, you can get parameters of coagulopathy. The problem with these tests is that, first of all, they're not sort of gold. They don't necessarily in and of themselves, by themselves, diagnose hemorrhage, but also there's a temporal delay in getting them. One study looked at the time it took to get from the drawing of a lactate to the lactate result is in your hands. Was roughly 45 minutes. So blood tests can be used as adjuncts to vital signs, but they are associated with delays. So we did this study in the trauma bay. We looked at 12 patients who received blood and used video review, what Dr. Hines was referring to. We've done this with many, many studies, and we looked at what were the delays between the time that the patient arrived and the time that the patient got a blood transfusion. And we looked at this as the events associated with this and the time of these events. And what we found was that the most common events that were associated with delays in getting blood was getting the blood cooler down to the trauma bay. Well, we fixed that problem about a year ago by putting a blood refrigerator in the trauma bay. That reduces the time to get blood by 11 minutes on average. But we found other factors, the rapid infuser that's used for giving blood quickly. People are fiddling with it, don't know how to use it, establishing IV access, doing other procedures which are equally important, like putting chest tubes in and intubating patients. But one of the key things is we found is that the decision to transfuse was also something that led to a delay. And if you look at the time delay associated with that decision, the average time was roughly 5-minute delay. And to understand the importance of this time delay, if you look at adults who get massive blood transfusion after traumatic injury early in their course, every minute of delay in getting blood is associated with a 5% increase in mortality. Now, it's not certain how this translates to kids, but clearly this decision delay is important. And we've done some other things for these other delays, but we're going to talk about this decision delay. So here's the idea. So this is Steve Moulton. He's a pediatric surgeon. He's just a guy like me. And he was kind of perplexed by this problem, is how can we diagnose hemorrhagic shock earlier in kids? And he came up with the idea is that if you look at the waveform of the pulse ox waveform, you can probably use that to identify which patients, when patients are about to go into collapse and deterioration, and that waveform may be able to be a way that you can diagnose things earlier. And so he worked with a team of machine learning experts. He came to them with this idea, and he developed what it's called CRI, or the Compensatory Reserve Index, and put this into a device, and this device is what we're now testing at our hospital. And here's how it works. So the device is basically a T1 tablet. It's a tablet that you can drop on the ground, you can throw across the room, sort of. And it basically, all it does is it measures a pulse ox from the upper extremity. And it takes that pulse ox signal and it uses machine learning to interpret the waveform and to come up with an estimate of how full the tank is. So this is the basic concept. And there's that tablet, and the tablet has some simple numbers in it. It has what the pulse ox is, it has what the CRI value is, and it has a history of what the CRI value is. So he had to test this idea, and this is how he did it. In collaboration with the Department of Defense, they took some soldiers and they put them in a vacuum chamber around their lower extremities, and they basically made them centrally hypovolemic. And by doing that, they were able to show that the CRI value corresponded with the level of hypovolemia. And then in a project in collaboration with Duke, they did controlled hemorrhage of human volunteers. And the way they did this is that you basically bleed patients in a controlled fashion, and then you're nice and you give them back their blood at the end of that bleeding. And so this gave the sort of the concept, the evidence that it needed to move forward into a clinical setting. And so does this idea work? So Dr. Moulton established a company. The company is called Flashback. This device is commercially available. You can go out and you can buy this and bring it into your hospital. And I'll show you in a moment what the ultimate goal of the device is and how it will be implemented. And this has been tested in a lot of different settings. It's been tested in the context of adult trauma. It's been tested in a pilot form for burns, congenital diaphragmatic hernia, deciding when patients need to go on ECMO, determining whether patients have perforated or simple appendicitis. It's been used to look at our POTS patients. Those of you who are at Children's National have lots of experience with POTS if you work here. And then for taking care of patients with congenital heart disease. So the most work has been done in the context of trauma, and because this idea came from a pediatric surgeon with an interest in trauma, that's not surprising. That's where the most of the work has been done, but it's been shown to be promising to look at hypovolemic states in a variety of different contexts. And so let me just show you a video graphic of CRI and how it works conceptually here. Let's see if I can get my video to work here. So what happens is CRI is I'll play this again so you can see. Here's the CRI value. And the CRI value declines, and you can see that the vital signs are sort of compensated. Is they slowly get worse, the blood pressure and pulse, the blood pressure declines, the pulse goes up, the oxygen saturation varies, but the CRI value much earlier shows evidence of volume loss. So this is the kind of evidence that we need to support testing this in a clinical setting. So the way that the way to think about CRI, it's sort of like a hypovolemic gas gauge, and it uses the patient as their own control. So it needs a few minutes of data before it can establish what the normal pattern is for the patient. But then it gives a value between 0 and 1, essentially like a gas tank. If your value of CRI is 1, you're normal volemic, and if it's 0, you don't want that. And that roughly corresponds to the different phases of hypovolemia that I showed earlier. And so this is one of their early papers looking at predicting hemorrhage. And the way they did this is they took adult trauma patients, they put the CRI device on them, and then they looked at whether CRI was able to pick patients who eventually got transfused versus just using the blood pressure. And the ROC here, as you can see, is substantially better for CRI compared to systolic blood pressure alone. So all the volunteer data, the initial clinical data in adult trauma patients, and then all these clinical circumstances where hypovolemia is a part of the pathophysiology of the disease, all these show promising evidence that CRI is a useful device. And so the company has gotten FDA approval, and here's the concept. You put the device on an upper extremity digit, and it goes through this machine learning thing, and it spits out a CRI value based on the pulse ox waveform interpretation. And so I've known Steve Moulton for a number of years as a fellow pediatric surgeon because of his interest in trauma. And I contacted him about 1.5 years ago, and I said, I have this problem, and I just wanted to know what things you think I should do to diagnose hemorrhagic shock earlier in our patients. We're just not doing a good job of it. And he says, I have the perfect solution. Let me get you my device. And so that's when this whole protocol got initiated. And so this is a research project we're doing in collaboration with his home institution, which is Children's Hospital of Colorado, Phoenix Children's Hospital, which had a simultaneous interest in seeing how this could be applied about the same time that I contacted Dr. Moulton. And he oversees a group of pediatric hospitals called Atomic that it's a bunch of trauma guys like me who are pediatric surgeons who are trying to figure out, using multi-center studies, how you can figure out how to solve some vexing problems in pediatric trauma. And so we did a power analysis, and in order to see how this device would work in injured kids for predicting hemorrhage, we predicted that we need 535 patients, and we're going to have probably between 12 and 15 centers, including our own, participating in this study. So the study design, here's the device. It basically uses a standard pulse ox probe. It's not the pulse oximeter probe that we use in our hospital. It's a different one. So you can't mix and match these. It's specific to this tablet. And here's the, you want to make sure the device works when you put it on. Make sure that you get a pulse signal, make sure you get a pulse ox value. And there's the CRI value. There's the gas tank. It's either 1 is normal or 0 is you're in bad trouble. And so our study design is that for every patient who arrives from the scene, we're eliminating transfer patients because transfer patients often are resuscitated before they get here. So there's a little bit less interest in that patient population. We're more interested in patients who are more acute in their injury. So the patients show up in the trauma bay. We put the device on the upper extremity digit, and then we either keep it on for 4 hours or 24 hours, depending on patient status. And so we call this the phases. Phase 1 is everybody has it on for 4 hours. We collect a lot of clinical data about their head injury, their volume status, what fluids they got, whether they were transfused. And then those patients who are at high risk for blood transfusion, we keep the device on for an additional 20 hours and then take the device off. And I have listed here patients that we have identified. Now, on this list also is traumatic brain injury. The reason this is on this list is that we're very interested in seeing how the pathophysiology of traumatic brain injury impacts CRI. So this is sort of a study within a study by including these patients in this part of phase 2. And so medical record review to get the parameters that we have. And then we were interested in things that indicate the need for blood. And those things are you got a blood transfusion, that's an obvious one. Maybe you had an operation to remove your spleen because it was bleeding. Maybe you had an IR procedure to deal with a bleeding blood vessel that was embolized. And so this is the basic study design. The study is completely unfunded. We're doing this out of the goodness of our heart because we believe that there's a real cause here, that if this device works, that this will have a significant impact on the care of kids. And this is its potential application. So here's the future vital sign monitor that's envisioned here, is that there'll be a CRI value. So the patient comes in and you put 2 pulse oxes on, or maybe a 1 pulse ox if we can figure out how to do it through the standard pulse ox that we have, and you get a CRI value. And so now you're looking at a value. And so even though the patient has normal vital signs, you say this patient may be in trouble because their CRI value is declining. So we've learned some lessons from, so right now this is CRI is being evaluated in ambulances in the Seattle area through a study through the emergency department at Harborview, and a large cadre of injured patients have had this device put on them, and the data has been collected. And that's sort of, they're using it in a pre-hospital setting. That required a lot of funding. We're doing it in a hospital setting where it's a little bit easier to just simply put the device on and track the patients in the hospital. And so we learned some lessons. We met with the Seattle team, the Seattle research team, to learn like what kind of things we need to do to make this successful. Is you want to keep the probe, it has to be on a digit on the upper extremity. It doesn't work if it's on a digit on the lower extremity, and that has to do with the machine learning and calibration of the device. Obviously, you want it on for as long as possible. You don't want to take the device on and off. If you need to take it off because of patient care responsibilities or some kind of medical reason, you can certainly do it, but we want people to put it back on. Right now, the device is not on a monitor, it's on a tablet. I mean, obviously the goal is to get this as another field on the monitor, but right now the device, it actually has to be plugged in. And what the investigators at other sites who have done this for a while have told us is that it runs out of battery and they lose their data. And then you got to bring it back. And so the devices can, so what happens is the trauma patient, so we put this on in the trauma bay, and then the patient moves all over the hospital. They go to CT, they go to the ICU, they go to the OR, encountering all sorts of different nurses and physicians and other providers. And then once that 4-hour or 24-hour period is up, we need to get that device back. And so we've come up with ways that in different units of where to put the device. And the device costs $6,500. So you don't want to lose it. And so we developed this protocol. got IRB approval. And I was pleased to announce on our research team meeting that we were ready to begin. Cindy, who is a regular participant in our research meeting because of her strong background in research and interest in her own research projects, said, I think that you need to do something different before you implement this. And let me turn it over to Cindy, and I'll let her share her screen. Then she can tell me what she did to help us here.
So I am very excited to work for trauma and burn surgery, especially with research, because I think that we do really good work, and it's exciting to be a part of that team. But when Dr. Bird brought this to our group, I was at first really excited, but then, am I frozen or can you see me? Okay, I froze on my own screen. So I was excited at first, and then I thought, oh, wow, we can't, there's going to be so many nurses from so many different units that are going to encounter this device. So I had a ton of questions, and I'll just go through some of the questions that I asked just from a nursing workflow perspective and how is this going to work? So my first question is the device compatible as a pulse ox with our monitors? Because I was concerned for that because of safety issues. Because if you have a pulse ox on a patient and it looks very similar to the ones that we have, and if somebody tries to plug one in and the patient has a low pulse ox, those few seconds of trying to plug something in that doesn't work could be concerning. And found out the device was not compatible, but it does fit in perfectly. It's one of those tricky things where it will fit into the machine, but it won't, it doesn't work. Which extremities can it go on? Can it be switched every 4 hours? So can it be taken off every 4 hours? Because I know for wound care and skin care and making sure we don't get any pressure injuries, which, the literature does not say we get a ton of pressure injuries from a pulse ox, but we are not going to have that be a problem in our research. Can it be switched? Can it be taken off and moved to a different extremity every 4 hours? Another question was how long is this battery life? How are we going to keep this plugged in? How long is the cord? I mean, it's questions that a lot of people don't think about. And I met with the one of the PIs from Colorado and asked them all of these questions before we really even started implementing of how long is the cord? And because one of the things they said is the battery kept on dying. Well, I was well, how long is the cord? Where does the device sit on the bed? And how far away is it from the plug? Another question I asked, is that case unbreakable? From being in the fire department and then being on transport and then working in the PICU, we break everything. So I was is this container really unbreakable? Because I don't know if anybody's ever seen a Pelican brief, a Pelican suitcase, but they're unbreakable, and I have broken one. And if I can break it, anybody can break it. Other questions that I asked was who's going to put the device on? Are we going to ask our nurses to add in another thing into their workflow when kids are already coming into the trauma bay? And there's so many things that are expected of our nurses that work in the trauma bay to prepare for the patient and make sure that they have everything in the room set up. Are we going to give them another thing to do? Or are we going to, even though it's very simple of putting on a pulse ox, is that another thing we're going to ask them to do? Are we going to put a number on it? If somebody has a question, do we have a plan to answer those questions and answer those questions in real time, not 2 days later, because 2 days later it's too late? What units are going to be affected? And then we counted the units, and it's 7 units. That's a lot of units in the hospital. I mean, the only ones that we're not going to see is the NICU and the CI and HEMONC, and probably not heart and kidney, but sometimes our trauma patients, if they had a previous cardiac issue or a kidney issue, end up on HKU after a traumatic event. Is there a standard place for these 7 units to put this device when it's time to take it off? Are we going to ask the nurses to take it off? Where are they going to put it? Is it going to be the same place for every unit? And we know that not every unit has the integration room in the same place. Not every equipment room is in the same place. And, will the device affect workflow? And the last two is, is it going to be plugged into the monitor? Because will our nurses be able to see what's on the screen, and are they going to be using that? Is it going to be in the monitor, or will it just stay separate? And is it going to need to be plugged in, and for how long? So those were all of the questions that I brought up, and I felt like Dr. Bird and the rest of the team were like, oh geez, Cindy, really? All of these things? And I was like, yeah, I really do think that all of these things are very valid and concerning. And so we took all of these questions, and instead of death by education and another cornerstone and mandatory things, we knew that this is not the way. So I don't like to say education and educating our nurses. I like to say buy-in. We got to get everybody on our team and on our side to get excited about why this matters. And yes, it might be a little bit more work, and we're talking like a very small amount of work to remember to like where to put something or change a pulse ox, but it's going to benefit our patients. And that's the long haul, and getting people to buy into the importance of every single day when we see something in research, to like kind of like your ears should perk up and be like, I want to do this. I want to help this. So it was not mandatory training. We put posters up in every unit. We made an education video that is 4 minutes long. So it's like the snapshot. It's like all the important things, and nice and short. And then we took that video and we had it vetted by nurses from most of the units that this device was going to go to. And we said, does this make sense? Or is this interesting to you? Is this too long? What's unclear? Do you have questions? And then we revised the video based off of the feedback. And then we distributed the video by email, but we also put a QR code on all of the posters. So you can access the video. It's on YouTube. You don't have to be on VPN. You don't have to like try to like log into RNs Connect or the intranet. You can get it right on your phone. And then this is the first year that we've done this, but so we hold Trauma Core once a year, and it's for our new nurses that come into the institution to give them kind of like the overview of trauma in this organization. And because we are doing so much research, and I'm so passionate about it, and I want everybody else to be passionate about it, I decided to include like a short 30-minute session in Trauma Core about our research and what we're doing. And CRI was one of those, one of the projects that we talked about. And right off the bat, I got, over 100 people now know about CRI. And what was really interesting is like my goal for the buy-in, when I got the evaluations back for that specific section of Trauma Core, over 60% of the respondents said that they had no idea how much research we were doing. And that's just in trauma. They just have no idea. And these are, new people to the organization, but there's a lot of people who have been here for a long time that have no idea how much research we do. And then they just saw a snippet of the research in trauma, which I think is like, it's great. That was definitely a win. So we have been running this, the experiment now, it's been running for about 2 months. And I just wanted to show you some of the challenges. And I'd love to hear some questions from you guys and some thoughts about how to overcome my last slide. So I have 2 slides. One, we're working on some of those, but the last one, I really would love to hear what you think, because it's still a problem with buy-in, and I would love to hear what you guys think. So far, we're only capturing traumas that happen Monday through Friday, 9 to 5, because right now we have our research team going into the trauma bay, like gowning up, going in, taking in the device, putting it on the patient, and then walking out. We've lost both devices. And as Dr. Bird said earlier, they're $6,500 a piece, and we lost both of them, but we did find them. They have air tags in them, which I don't know if you've ever, wait, you know what? I have one in my pocket. This is an air tag. So we have this is a little thing from Apple that we have slid into the case. And what's great about air tags is you can tell where the air tag is and the device, but not that well. We'll know it's on the campus, but we can't, it doesn't tell you what floor. And you can make the device make a noise, but you have to be within 100 feet of the device to make the noise, and it's not very loud. And you also can't hear it in the case. So there's that. So the devices still have, they haven't been remained plugged in. So we've lost some data because the devices did not stay plugged in. We learned that our research assistants were having difficulty tracking patients in the hospital. So that's an easy thing to fix, but it's not something that we anticipated right off the bat. So when we lost the two devices, I asked the research assistants, well, where'd the patients go? And they're like, oh, they were both discharged. I was like, are you sure they're discharged? They're like, yes, they're discharged. I went ahead and I just looked them up and I was like, nope, one of them went to the PICU and then they went to neuroscience. Then we went to the PICU. That's where the device came off and we found one of the devices. So now our research assistants know, even if they think that the patient was discharged, just double check to make sure that they still aren't in the hospital. And then, so those are our challenges so far. And most of them we are definitely working through and getting a lot better at. But for one of the time that I was talking about when we lost the devices for over 36 hours, and I was like greatly distressed over this. I went through all of the documentation in the emergency department and like looked up who the nurse was. And then I texted the nurse because I happen to know her, we're friends. And I was like, and I'll show you, and I screenshotted these messages. So I said, hey there, quick question for you. Did you take care of a patient with the CRI device? I said, no. Not that I know of anyway. Then I sent a picture of the CRI device and I said, well, it looked like this. And then they said, oh yeah, the study. So they knew about the study because they saw the poster. And I said, do you know where the device went after the kid left? I can't find it. And they wrote back, no, very busy on Seaside, wasn't something I focused on. And that's what I would love to hear, because I don't know how to get the buy-in of really busy people and not losing devices that are that expensive. And I'd love to open up the floor if you have any questions about what I said or what Dr. Bird said, or if you have any ideas of like creating more buy-in with our nurses. Clarissa, I see your hand up.
Hi, Cindy. Hi, Dr. Bird. Wow, I'm like, I'm excited about this research that you are doing. And I also happy about the questions that you have raised, Cindy, because, I'm an informatics nurse, and these thoughts are the things that I usually go through when we're making changes or innovations in the system. So like some thoughts that I have, I mean, we have issues with tablets being missing. We put like some of them put a pole, but still you can still lose that. I have a question. Is this already in Cerner?
No, it's not. It's not in Cerner because we are just validating, like as Dr. Bird was saying, we're just validating whether it works in children or not. And so no, it is not in Cerner.
Not yet. Okay. Okay.
No.
Yes. Yeah.
That won't be for a really long time down the road if it works for kids and if we decide to use it in this institution. Right now, we're just part of the validation process for pediatrics.
And then last question, is this something that like maybe Philips would be interested in putting into their monitor so that it would be configured there and then you could just use the same, like whatever, like you'll have one thing to use?
Yeah, so that's the ultimate goal. But in order to have Philips interested, they need to show that this works, and that's what we're doing, and that's why it's a separate clunky device. And ultimately, I mean, the company's business model is to sell this and license it to a monitoring company like Philips or Siemens. I mean, that's the long-term goal.
Okay, thank you.
Yeah, thank you for those questions. It's and I'm glad you like the questions that I asked because, well, I mean, I've worked with you too, Clarissa, on like putting things into play. So yeah.
Yes.
Eileen, I think you were next.
Yeah, thank you, Cindy. And I think you're conducting a second study while you're actually studying the device. And I would just want to call your attention to the fact that you're actually conducting an implementation study of a new novel device. So I think the nursing question there would be, because it has so many implications for nursing in terms of the process, that you might want to consider that for a nursing study. The second is, can you change the color of the probe? Could you make the sensor like bright red? Is there Is that possible? And then the third, to overcome some of it, I really like the fact that you're using a QR code for your education. Could you put on the device a QR code? If you've never seen this, scan this, because all the nurses have, so that you could educate them kind of real time if they haven't seen your education in the past.
Yeah, I mean, it's a good idea to try to make I think you're right. This went from a research project about a device to an implementation challenge, and we still, as Cindy said, we still have a lot of those challenges to address. And clearly, a force function like the way to solve the probe problem, I think, is like the first question was. Just get it on our monitors and use the standard pulse ox probe. Well, that's the obvious long-term solution. But the systems approach here is make it so you can't plug this into the wrong device. Make sure the pulse ox probe doesn't plug into the wrong device, or make it visually different. Now we can't really make it visually different because it's got to come out of a sterile. It's got to come out of a package. And we can't change the color of it. But I think that these are the long-term, the long-term solution again is not have a separate probe, have the same probe.
And Dr. Bird, I said exactly what Eileen said to our research assistants about, like, I was really worried about this probe and it going into the monitor and it not working. And what we have done that I did not include pictures of is there are very, very bright fluorescent labels on all of the research probes that say for research only CRI device, and they are bright and they're long, and we have two of the, like, if you think about like IV tubing labels, they're about twice the size of an IV tube label, and it's at the top, like right where it hits the finger and where it goes into the machine. So no matter where you see, you're like, oh, something's different. Like, we don't normally label pulse ox probes with stickers, and they're extremely bright. They're quite obnoxious, but that is one way that we handled that. And what was the second part? I'm sorry.
About the implementation. I mean, I think that's a question for you because you're kind of conducting it simultaneously. The other, and I do think I have one other question, and I think temperature, but I think you're capturing temperature, and so you can probably do that analysis, because with kids, temperature seems to affect their physiologic status. But I looked on the screen, your machine learning will factor that in.
Well, so the device itself is really focused on pulse ox signal. It doesn't incorporate other variables. It really looks at the pulse ox waveform and changes in the pulse ox waveform. And I think there's something like 40 different parameters that they've identified using machine learning. And all this is proprietary and part of the company's intellectual property. But it doesn't incorporate other data. I mean, clearly that's the next phase of this. If this works or needs revision, then inputting other variables would be useful.
I think Kathy had her hand up as well.
And there's a couple of questions in the chat box for you too. Kathy, go right ahead, please.
This is very exciting. I got to tell you, I was one of the reviewers, Dr. Bird, and soon to be Dr. Colson, for the IRB. And my biggest concern were that of logistics, all those questions, Cindy, that you talk about. And I can tell you, I've been on the IRB for a long time, and it is so nice because the trend over the last several years has been getting the right members on the study team. You know, I can't remember how many protocols I reviewed where I said to the PI, most of the time a physician PI, you really want to get a wound nurse on with you, or you really want to get, you know, some key person like yourself that can talk about the logistics of this whole thing. And so I just find it just so exciting to have you guys here and to know what happened, you know, because we review these protocols and then they go on, you know, to live in the research world. But I wanted to tag on a little bit to what Eileen said. As far as the communication, is there any way, do you have a way of connecting, and maybe a QR code is a way to go, but can you put information on the device itself?
Yes.
Whether it's like a laminated something to give basic information.
Yes, 100%. And I forgot, that was the last part of Eileen's question. So there is a laminated sheet that is zip tied to each device that has the link for the video. So the QR code isn't in there, but it's a bit link. So it's very short. It's like bit.ly CRI device. It's written on there. There's a phone number that can be called if you have a question, like, what is this device? Call this number if you have questions. Remember to plug it in. And also like the link to the video and a couple things that say this isn't compatible with regular pulse oxes, and like kind of like the 5 very important bullet points for all of the information. So that is attached to the device with zip ties, as well as additional CRI probes for that patient, because that was another thing that we brought up, like, you know, kids throw up and mess up their devices that we have on them all the time. And I was like, well, what are we going to do about that? And then we got like a pencil case, you know, the ones with like the 3 holes that you put in a 3-ring binder, and it has a zipper. So we have a place to put the tags. They're already pre-labeled, and it's zip tied to the device with the laminated sheet that is zip tied. And I will say, we haven't lost one zip tie. We haven't lost one bag, and the laminated sheet is still intact. Even when we lost the device, everything was still intact when we found it. So we did do that.
Oh, well, very good. And what was the last thing I just wanted to mention? Oh, it's left my mind. Anyway, I'll raise my hand again if I think about it. But it had to do with, oh, I know. When I was listening to Dr. Bird, and he talked about, like, you know, it can take a certain amount of time to, you know, 5 minutes. It delays it for 5 minutes. That little piece of information, I think, is so compelling that when you talk about buy-in for a clinical nurse, if you could somehow have on, you know, on the information that you give them, that highlight of why you're doing it, you know, that specific, you know, help us, you know, decrease this, you know, to, you know, or something that just kind of grabs them. Because when he spoke about in terms of minutes within the trauma bay, that I found so very compelling. That was my buy-in 100%, you know? So I don't know what you could do, but something that just kind of grabbed them, that was attached to the device, you know, maybe on that information sheet or something. Anyway, just an idea.
Yeah, I think that's a great idea. So we're doing another project where we're trying to get people to comply with getting patients to the operating room with head injury promptly, with life-threatening head injury. And we've used that same concept, is that I think that putting out as a banner is what 1 minute of delay represents in these different contexts. And people who work in the field and know the studies know that information, but we need to get that information to people at the bedside so they know that why we're talking about minutes, like why 5 minutes matters, why 1 minute matters, and how does that translate the outcome. I don't have the perfect solution, but that's the banner you need to show.
Mm-hmm. Mm-hmm.
I just wrote all of that down as notes. So thank you.
Great. Yeah. Cindy, Dr. Bird, if I could take you to the chat, there's a comment that says, sounds like CNH needs a medical device tracking system, real-time location system for hospitals. And then if I just drop down to a comment that's linked to that, Jill Board says, thinking the same, bright neon color. And Sean Virgil says, to prevent data loss, can you make the tablet beep every 2 minutes when there's a low battery? similar to the low battery alarm on smoke detectors. So I'm going to give you all of those comments at the same time, and there's just a couple more, but please go ahead with those.
Yeah, it's so, the problem that we faced, all the other studies, and I showed you the different domains that's been studied, all the other studies were done in a single domain, a single medical domain. We're doing this in multiple medical domains, and that's why we're up against these problems. So some of these problems we can't really solve because the device is what the device is. It's an FDA approved device, and even doing things as simple as having a fire alarm style alert, or changing kind of like how the information is presented on a screen. All these are very expensive changes that their engineers have to stop and do. And again, this is a transition device. That's the thing. This is a truly transition device where it's being, we have to put up with this tablet and all its quirks, its battery life, it's all these other things, as the step to getting this actually on the monitor. And then once it's on the monitor, I believe all these problems will go away. These are research problems. These are research problems. And and there are limits to how much we could do. I mean, we can put neon colors on it. In Colorado, they've wrapped it with colorful bubble wrap. So there are some visual things that we can do. But in the end, it's a research device.
And I feel like hearing Dr. Bird say that, it reminds me of the quote, art imitates life. I feel like sometimes research imitates life. So I think that this project in particular has shown us some of like bigger problems within the hospital that we could possibly think of in the future, especially with like pieces of equipment walking away. Like we're having this problem because we're doing a research project, but there is a bigger problem of equipment walking away. I did work in a hospital before where they had with the trackers on the devices, but the technology then, and I don't know if it's changed now, is it was still the same problem. You could tell that wheelchair was in the hospital, but you couldn't tell what floor it was on. Was it in the garage? Was it outside in the ambulance bay? So, and as Dr. Bird was saying, that stuff is like very expensive. So it's not something we're going to fix for this research project, but I appreciate the fact that I feel like research does imitate life, because you find you're like, oh, wow, we found all these problems. Like, let's fix everything. And it's like, we have to remind ourselves to stay focused and just on, validating this device, helping to validate this device for kids.
But how you're tackling this really has positive implications for other forms of clinical investigation as well. So now I'm going to take you to the next set of comments. And Jules Sherman is saying, I'm wondering how buy-in with nursing to learn and test new devices could be improved from a cultural standpoint. What sort of incentives or protected time might improve enthusiasm for understanding new research and the testing of new research? And Paul Manicone responds, agreed, that's the burning platform for buy-in. Jules continues, so it's a question of disseminating important information to the nurses at the bedside to understand the importance of the technology. Would you two like to address that?
Yeah,
well, I think that was the question that we were asking you guys of like, how do we get the buy-in? Sorry, Dr. Bird, I didn't mean to interject.
Well, yeah, I mean, I think Cindy and I have talked about this. I mean, I think that there's a lot of different layers of this. The first thing is that we're doing this because we want to help kids.
Yes. We're
getting zero funding from this, and partly because the company doesn't have the resources to do it. And my national collaborators, when I've asked them, say, we're doing this for a device that will benefit this company, and they say, we're doing this because we're trying to help kids. And I think that getting that message out, that this is not a funded research project that I'm making money off of, or Cindy is making money off of, or anybody is making, even the hospital is making. We're doing this for the benefit of kids. I think that message, and even with funded research, all of us who have funded research realize that you're never really funded for what you actually perform. Right. In some very rare grants that I have been, but it's pretty rare. And I think getting that concept out is that there's a lot of altruism in all this work. And I think that's a message that I don't think until this project, I really didn't think about that much. And maybe Cindy can comment about other ways that the bedside nurse who comes in and does a shift, how can we change their view of participation?
I do like your point about altruism, Randy, and I would say to you that our nurses at the point of care can also get CAP points for their career ladder by participating in research, and by helping you with this device is an example of helping with research. So that would be worth discussing, Cindy, with the CAP committee. And I think this would be very well understood as a structural change and a value for nurses at the point of care. Yeah, we'd love to see that. I love that messaging of altruism, and yet at the same time, being able to promote career points. Very nice. All right, so let's see. I'm gonna go back. Cindy, you mentioned to use Excel in the NICU. We screen CCHD in the NICU, and I heard you can also use this for congenital heart disease. That I think she may be talking with the pulse ox. Susan Keller would like to know, how is study recruitment going? Are you coming close to the sample size that you need?
No, not yet.
So the way we started this is there's 3 sites that really were the vanguard for this, in sort of like are ironing out all the problems. And we've now gone back and we're going to revise our IRB protocol to push this into the 535 patient recruitment at 12 to 15 sites. We've recruited, I believe, latest number is roughly 10 patients over 2 months. We're doing a whole lot better than Colorado, who has less than that since the beginning of the summer. So we're doing better. For some reason, Arizona, they're able to get this on every patient, mostly because their IRB allows anybody to put the device on, not just a research person. And so there's marked differences in the IRBs and the regulations at different sites.
Wow, so they are probably not limited then Monday to Friday during daytime hours. They are probably getting weekend activity as well, I would guess.
Oh yeah.
They might have more eligibility then. I'd like to go to Raven McLeese. She's talking about for buy-in having unit champions. Raven, would you like to speak to that important comment?
Just saying, I know that we have champions pretty much for lots of things, but ideally, if it could be part of a existing program, for example, the safety champions, where they are already something that's embedded in many of the units, and they could serve as sort of that, person on the ground that people could reference to say, okay, I did see the device, this is where it was last, and maybe just some important points about, handling the device or getting it back to you guys. Just something to use, again, an existing system that's already in place.
That's the neatest. And maybe Cindy could chat with you about whether we have safety champions on those 7 units. That would be another great possibility. I know that I'm going to lose every one of you in just a moment, but gosh, has this been terrific. I really want to thank Dr. Bird, Cindy Colson, and every one of you as participants in today's discussion. I can't tell you what a thrill it is to listen to each of you, to read and look at your comments. Thank you, every one of you, for caring about new knowledge and the interface of research, clinical expertise, and what can result. We look forward to having you join us for the January Conway Chair Conversation, where we're going to continue the theme of the oxymoron, I know, rapid research. More to come. Please look for the next flyer. Our very best to everyone.